I think we've got a huge responsibility as healthcare clinicians in wherever we work to try our very best to make sure that those last hours in somebody's life is as good as it possibly can be. And of course, this was Dame Cecily Saunders, who was the archetype multidisciplinarian, in that she was both a doctor and a nurse. So, older patients account for up to 25% of our ED attendances, and I think Professor Coates had a very good slide up earlier this morning about the amount of older patients that we actually see in the department, and this is going to increase. And I think that we need to sort of get to grips with this, because it's like somebody said earlier, surgery is sexy, geriatrics is not. I think we need to change our whole thinking on this issue. In a 2011 survey, 43% of bereaved people said they thought the care for their loved one in the last 3 months of life was excellent or outstanding, and that's great to hear. But 24% said it was fair or poor. And these findings suggest that it's just not good enough. And they are the people who will remember the death, that 24%, and probably remember it in a distressing way. So a recent survey by the Sue Ryder organisation, survey was undertaken by Demos, demonstrated that 78% main priority at the end of life was a pain-free death. Most people are terrified of dying in pain. 71% wanted to be surrounded by loved ones. 53% looked for privacy and dignity. 45% being in familiar, peaceful surroundings. And 63% wanted to die at home. But only 27% felt that it would be possible to die free of pain. And that's actually very sad to think that we as clinicians cannot reassure people and cannot demonstrate that actually you can die a comfortable, peaceful death without pain. So end-of-life care is defined as enabling and supporting the palliative care needs of both the patient and family to be identified and met throughout the last phase of life and into bereavement. And this includes management of pain and other symptoms and provision of psychological, social, spiritual and practical support. Palliative care has been defined by the World Health Organization in 2002 as an approach that improves the quality of life of patients and families facing the problems associated with life-threatening illness. And this is through prevention, relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial and spiritual as well. But palliative care in the ED is challenging, and the goal has to be that one, it's a multidisciplinary issue, but also that we are there to preserve the dignity and the humanity of the person and to relieve suffering rather than expending valiant efforts to prolong a life which holds little or no quality for the person. This is a kind of a double-edged sword, and it's quite difficult whether this, is something we should really be sort of getting in there and resuscitating with aggressively, or should we be identifying that that person's life is nearing the end and we should be making them comfortable and reassuring the family. So the sort of boundary between palliative care and emergency care needs to be much more clearly defined. And there are problems with this. Increasing longevity and effective management of chronic progressive illness has created a great need for ED physicians to develop their skills in palliative and end-of-life care. And that goes down as a sort of, a dead weight with some people. They think, that's not what I came into emergency care for. But other people actually see it as an opportunity to develop additional skill set, scope of practice, especially as so many of the previous ED skills have been more recently subsumed by specialties. So, for example, the strokes get sort of zipped off, the cardiac patients have to go for PCI, etc. And even minor injuries have been largely overtaken by urgent care centres and private groups in a lot of places. So there is a real need for ED clinicians to get more involved in the whole scope of palliative care. But most importantly, I think longevity in our patient population has raised awareness of the scope of palliative care and end-of-life care, and knowing that we can do something for our patients and we can assure them of support in symptom management. However, a study by Smith more recently, and I think it was 2009, found that there was significant confusion and discomfort among emergency physicians in caring for patients with palliative care needs. And they commented that there was a belief that palliative care is equivalent to hospice or end-of-life care. And yet there are people who are, living in the community with palliative care for years and years and years, and it's something we need to get much more to grips with. So, in principle, good end-of-life care in the ED should be achievable, but there are little issues. Actually, they're probably not really little issues at all. Good end-of-life care in the ED is almost the antithesis to what we traditionally believe our ED role to be. I always ask people why they want to work in ED, and I've never ever heard anybody say, because I really want to look after people at the end of their life. I'm just waiting for somebody to say that. I was delighted when I interviewed a nurse once, and I asked her why she wanted to work in ED, and she said to me, because I love looking after tramps. And I thought, right, you've got a job. And she was really honest, and she was absolutely fantastic with our homeless population, etc. But I've never heard anybody say to me, because I really want to look after dying patients or people at the end of life. So what are the challenges and the concerns, and what are the impediments? Well, there are quite a lot. And in the first instance, and at the centre of this has to be patient expectations, and we have to sort of be able to understand what our patients' expectations are. And quite often elderly patients will say to you, I don't want you to be, jumping on top of my chest. I don't want you to be giving me loads of new medicines, and please don't stick any needles in me, and I don't want a catheter, and I don't want this. And I think we need to really listen to what our patients are saying. We tend to dive in quite often. I think going up to the far corner, paramedic predicament. Paramedics are put in some awful predicaments in bringing elderly people into hospital. And quite often what happens is there may be somebody they're called to a nursing home where there's an elderly person who may well have an advance directive or may well not have an advance directive. But there's confusion and concern and worry that the person has deteriorated. They have people in the carers in the home who may not be very comfortable with the person dying, or maybe the symptoms have got out of control and they feel they can't control them. So the sort of default is to call the ambulance, and the paramedics get there, and quite often they are put in a predicament that they feel, well, we really could leave this person here, and we could get the GP out, and we could do this, but the families may not be happy with that, or the home may not be happy with that, and then that poor person gets, traipsed into an ambulance to hospital. So that is a major issue we need to sort of tackle. Structural and attitudinal issues are a big problem, really, and somebody mentioned the dreaded 4-hour target earlier, and there is such pressure to move people through that if somebody is dying, there's this sort of frenzy, let's get them into a bed, let's get them to a ward, whatever. Actually, very often what happens is the poor nurse takes them to the ward, they get into a bed in the ward and die that minute. The ward is hacked off because you brought them somebody who they now have to lay out and do all the sort of, post-death duties. And it's a horrible thing to happen to a family. You can just imagine, going in the lift to the ward or whatever with this poor person who's just about to die. I think we should be able to identify these patients and say, no, we're not going to move them. Let's get them into a quiet area and let's make it good for them in our department. Crowding, of course, is a big problem, and crowding in our departments is not just in this country, it's in every country in the world, crowding. And it makes it, even if we can isolate the person in a little room somewhere away from a bit of the noise, it's still a frenzied environment for somebody to die in, and it takes a lot of effort, and it definitely definitely takes really good leadership to make sure that that person is looked after with privacy and with dignity. So it's an ongoing challenge for all of us. Family expectations quite often are issues, because quite often the clinician will decide that, well, we're not going to sort of intervene too much here, but the family want it, and for various reasons, and that can be very challenging. It can be challenging to sort of be the patient's advocate, the person's advocate, and also to manage the expectations of the family. And clearly some people are much better at doing that than others, but you can quite often hear doctors and nurses saying, yeah, but the family, they really want us to do everything, they want us to try harder. Even in situations with witnessed resuscitation, you very often have families saying, no, please keep going, keep going. And it's so undignified and it's so wrong in situations, but it's a big challenge and it's an impediment. Unidentified traumatic injury and catastrophic injury, these are two sides of a double-edged sword, and I think there's, it's very sort of raw at the moment how we manage older patients with traumatic injury. One, we under-identify a lot of it, and we've already heard a lot of that this morning, about the sort of seemingly minor injuries, the falling over from standing sort of thing, but actually having quite a significant head injury. And then there's the catastrophic injury that may not actually be as catastrophic as it seems initially. And again, there's been some mention of older patients actually doing quite well with neurological intervention. So it's challenging to actually change the sort of the thinking around trauma and to make sure that we do identify these patients. There is also more recent evidence that older patients actually will often have a higher GCS when you would expect them to have a much lower GCS. So in the presence of quite significant traumatic brain injury, they can still have a reasonable GCS, which lulls us into a false sense of security. Actually, they're not too bad, their GCS is fine. Actually, it's a very bad sort of indication. And I'm just going to mention organ donation because very often it's not considered, and yet somebody with a traumatic brain injury who's older, who may well have been extremely healthy, should be considered for organ donation, and that thought should cross people's minds, and it doesn't often, but then that is also an impediment to end-of-life care. It's something that would need to be really, really well managed in end-of-life care. So what are the priorities for care? Well, following the discredited Liverpool care pathway, the Leadership Alliance for the Care of Dying People published two documents in 2014. One was One Chance to Get It Right, and the other one was Priorities for Care of the Dying Person. And these are clear documents which set out the approach to caring for dying people that health and care organisations need to adopt. The 5 priorities focus on recognising that somebody is dying and communicating sensitively with them and with their family, definitely involving them in decisions and supporting them and their family, creating an individual care plan that includes adequate nutrition and hydration. So how do we recognise that somebody is dying? Well, it does take, you do need to have somebody competent to actually assess that patient. It needs to be a doctor who's competent to judge whether this change in condition is treatable or whether the person is likely to die in the next few hours or days. And then it also needs to be consultation with the team, that if this person is likely to die soon, it must be communicated sensitively and, if possible, to the dying person and to the family. In catastrophic trauma, where the injury is not compatible with life, the clinician needs to be honest and open with family and carers. And any decisions or interventions taken need to be regularly reviewed and revised, as the situation might change and does change. So healthcare staff also must allow time to engage with the dying person and their families, actively listening and responding with empathy to their distress, worries and concerns. And I think generally people are very good at this. I think the things that make it difficult is crowding and the volume of work, but I don't think they're good enough excuses for not giving your time to somebody who is dying. So assessment of patient's condition must be discussed honestly with family and important others, and they should be provided with very clear explanations. Clinicians must make every effort to answer queries and not fob them off or not gloss over it or say, oh, the doctor can't speak to you soon or whatever, or I'm not looking after your relative at the moment. None of these things are good enough. We need to be answering the questions as best we can. And if we can't, getting the right person in there to answer those questions. All discussions should be in simple, plain language without using euphemisms. I'm not suggesting people are stupid, but very often in a stressful situation, people don't understand what you're saying. So you need to probably repeat yourself, and sometimes you need to sort of paraphrase or summarize what you've actually said. And difficult conversations should not be avoided. Any ambiguities or disagreements about the plan of care, they need to be acknowledged and resolved. So if the family are not happy with the way the treatment is going, it needs to be discussed with them, it needs to be explained to them, and they need to be part of that decision-making process. So involving the patient in decisions, well, as far as possible, we should be involving the dying person, and they should be involved in decisions about treatment and care. They definitely should know the name of the doctor, and they should know the name of the nurse who's looking after them. It's really important, and you see this all time and time again when you get sort of compliment letters. They nearly always mention the name of the doctor and the nurse, or if they don't remember the name, they say, I'm so sorry, I don't remember the name, but that person was so lovely to us, or whatever. And it's really, really important to do that. It sort of personalises things for the patient. And I think the other mistake we make is quite often you walk past a trolley and you see a little old lady on the trolley who looks like she hasn't got a clue what's going on. If you take the time to stop and talk, quite often you find they know exactly what's going on, and they actually are just accepting what's going on. So don't make that assumption that they are confused or a bit demented or not really aware of what's going on. And even in sort of early dementia, quite often they'll be very aware and will tell you exactly what is going on or what you think is going on. I remember one patient who apparently had dementia was in a cubicle opposite to our storeroom, and I'd forgotten the number of the storeroom. And I called to one of the nurses who was a bit, sort of, not too far away from me. Do you remember the number of the storeroom? And the patient called it out to me. And she said, I've been here so long, and I've heard so many people asking for it, I know what it is. She was down as confused. Well, she certainly wasn't confused about the number of the storeroom. She could have gone in and got stuff out. I think respect for dignity must underpin all our actions. And I thought this was a really lovely quote from Maya Angelou about dignity and respect. And it says, it means a belief in oneself, that one is worthy of the best. It means that what I have to say is important, and I will say it when it's important for me to say it. Dignity really means that I deserve the best treatment I can receive, and I have the responsibility to give the best treatment I can to other people. And I think if we think like that, we will get it right. We so often, not by our actions, but really by our omissions, erode the dignity of the person by not involving them in the way we should and denying them their sense of agency and autonomy. Supporting the family and the patient, this can be challenging in terms of time pressures, privacy, and ensuring a quieter place for the family and making sure the dying person can be together. This can be particularly challenging if you have a very big family or a very caring family. Quite often this is the case, particularly in ethnic groups. You will have very big families that can be very challenging because they all want to be there and they have a right to be there, but we have to kind of manage those situations as well. Ideally, we should be able to move a dying person to a ward, but not at the last minute, as I mentioned earlier. It can't be one of those lift things into the bed and then die. That's dreadful. That's just so, it's so inhumane to do something like that. staff need to be made aware of the need for privacy. And when I say that, I mean you need to let all the staff know, room 6, can you just not have a big laugh and a joke outside that room, or can you just tone down the noise outside that room because the person in there is dying, and make it a little bit more respectful. I think explaining to the family what to expect when death is imminent is such an important thing to do, because people get very frightened, and this is why nursing homes very often call an ambulance, because they don't recognise things like chain strokes, respirations. They don't, that sort of distress frightens people. They think, oh my God, they stopped breathing, oh, they died, and then there's a sudden big gurgle and the family are terrified. So I think it's very important to explain that, the breathing's going to get actually slower and slower, but you can keep talking, you can keep holding their hand, whatever, and make it quite clear to them that things are going to change bit by bit. Creating an individual care plan is really important. That includes nutrition and hydration, symptom control, obviously, psychological, social, spiritual support, all coordination and delivered with compassion. And I think it's very important that the family get the impression that you are doing everything you possibly can, and not sort of giving up on them, so to speak, as the surgeon earlier mentioned about the photograph. I thought that was pretty good. Symptoms that will require treatment are pain, obviously, difficulty in breathing, nausea, vomiting, constipation, depression, dysphagia, insomnia, incontinence, and anxiety. And anxiety about being incontinent, that is something that distresses so many patients, and it's something that we can so easily deal with, and we need to make sure that we do. I think, the decisions have to be made about whether there's a need for intravenous cannulas, or whether these things can be just, not done. And certainly urinary catheters as well, things that are going to be distressing for the person, is absolutely essential. If it's going to aid their comfort, then, well and good, but if it's going to actually distress them and, impair their dignity and that, then, we should think differently. Now, I know Christian has gone on a lot about pain, and he did a very good session on that, and I said, oh God, I think I'll just skip my slides on pain. But actually, I think it is all part and parcel of looking after the older patient who is dying. It's the most obvious area of symptom management, and one where the typical emergency department practice presents challenges. And the challenges are that we do prescribe opiates and non-opiates analgesics routinely, but we're also very wary of prescribing opiates. And emergency clinicians are the ones that say, "Are you sure they need morphine? Are you sure? Are you sure they're not just looking for it? Or have you considered that these people are drug users or whatever?" We are very wary, and for good reason. But we need to think very carefully about the older person. Emergency medicine training advises the physicians to avoid respiratory, cardiovascular, neurological complications that can arise or result from excessive dosing of acutely ill and often unstable patients. So it's quite challenging to get the balance right in the emergency setting, but like for somebody who's on 400 milligrams of oral morphine a day, and we then decide to give them 5 milligrams, it's not going to touch them. It's a drop in the ocean. I just wanted to say a little bit about diversity in death, because it's really, really important, and this is an area that we can offend very easily by not being well informed. We live in a multicultural society where death and dying are understood and experienced within a complex mosaic of cultural and religious meanings. And in some patriarchal societies, women may be excluded from some of the rituals. And where I work in Imperial College, we have a large Arab community, and quite often the women are not brought in to the resuscitation room, at the end. And this can cause problems, certainly if you feel that they are distraught and distressed. And we have had one or two situations where the male members of the family said, "No, this isn't the place for the women. This is for the men," sort of thing. things. So you need to be able to manage these sort of issues. But it's also very important to recognise and respect that each society characterises and treats death in its own individual way, and it's very easy to offend in these situations. So I think it's very important if you have got a person of an ethnic minority who is dying, is that you ask the family, what would you like us to do? What would you like us not to do more? And quite often families have asked if they could wash the body after death themselves. I think that's perfectly acceptable, because it's quite unacceptable for some cultures for non-family members to wash the body after death. And so it's challenging, and it can be very difficult, and there's issues around post-mortems as well. But I think all of this can make up a very good or a very bad end-of-life experience for a family. So it's stuff we should really get to grips with and make sure that we don't cause upset by omission in any way. And our communities are growing, and by 2026, our older ethnic minority population, which is less than 4 million aged 50 and over, 1.3 million aged 65 and over. So we're going to be seeing a lot more of ethnic minority people and diversity in our department. So we need to be able to respond in a very sort of effective way. I think it's very important that you again ask the family, is there anybody you'd like us to call? Do you have a priest or a chaplain or an imam or whoever, a rabbi, and that we have the names of these people at hand, and that we're not rooting around at the last minute thinking, oh God, who is it? And I know that's stuff that does, it isn't seen as a priority, but actually it's important stuff, and it's very, very important to some people. I know that people will think that it's just dreadful. Some Catholic people will think that it's dreadful if you die without a priest there, or the priest hasn't been to see you before you die. And similarly, a lot of Muslim patients would like to see the imam as well. So I think these sort of things are really important to contributing to making it a good death for the person. The gap between the availability of organs for donation and patients desperately in need of transplant remains very high. And we don't often think about it in older patients suggesting organ donation, but actually, as I mentioned earlier, there may well be a case for it. And very often, the people who've had a very traumatic injury and are not going to survive may have had a very sort of healthy lifestyle up to that point, and could possibly be very good donors. And again, that might be a complete anathema to the family, but it might also be very consoling to some people and very reassuring. So we shouldn't sort of shirk away from asking that question. So, in essence, I think the key qualities needed when caring for dying patients are kindness and compassion and thoughtfulness. I don't think any of the impediments that I've put up are excuses or good enough reasons not to make sure that somebody in our department has a good death. I think we have to make difficult decisions. We have to discuss all care options with the family and with the patient wherever possible, including organ donation. But we should do it. We shouldn't shirk away from doing these things. And I'll sort of end with the much unhappiness has come into the world because of bewilderment and things are left unsaid. I think Dostoevsky said this, and I think it's actually very true in essence. And then I just wanted to recommend a couple of books I've read recently, and I think if you're all looking after older patients, you should definitely read these. Elizabeth is Missing. Has anybody read it in the room? Did you enjoy it? It's very interesting. I found it a bit hardcore to begin with because it is about a demented lady. And I thought, I don't know if I can do this because my dad died of dementia and it was very near the bone in a lot of places, and it made me feel very guilty because the daughter was saying things to the mother that I thought I probably said to my father. I told you that a minute ago. But it is a really good story. It turns out to be actually a murder mystery, but it is very good for clinicians caring for older patients because it really gets you inside the head of the dementia patient. So you have to have a go with that. And I'm sure you're all familiar with Atul Gawande, are you? An American doctor. he's written a few books, but this last one I think is really interesting because he gets to grips with mortality, and it's a sobering read for any doctor or nurse, but a very good one. So I would recommend that. And I'm a little bit evidence-based and a lot of just soft science, but thank you for listening anyway.